Good afternoon and welcome to the Department of Medicine's Grand Rounds. Next week's Grand Rounds will be Chief Resident Grand Rounds titled Telehealth, Where Do We Go From Here?, which will be presented by Dr. Chelsea Goodyear, Chief Resident of Internal Medicine Pediatrics and Clinical Instructor of Medicine at University of Maryland School of Medicine, and Colorectal Cancer Screening, What's on the Horizon, which will be presented by Dr. Andrew Ma, Chief Resident in the Department of Medicine at Mercy Medical Center and Clinical Instructor of Medicine at the University of Maryland School of Medicine. Today's Grand Rounds is titled Data and Informatics, the Foundational Element for Clinical and Translational Research, Considerations and Opportunities, and will be presented by Dr. Warren D. D'Souza, Vice President of Enterprise Data and Analytics at the University of Maryland Medical System and Professor in the Department of Radiation Oncology at the University of Maryland School of Medicine. In 2015, Dr. Warren D'Souza was appointed as the Vice President of Enterprise Data and Analytics for the University of Maryland Medical Systems. He led a system-wide effort to develop a robust data and analytics strategy, culminating in the establishment of an Enterprise Data and Analytics Division in 2016. Prior to this role, Dr. D'Souza was the chief in the Division of Medical Physics in the Department of Radiation Oncology at the University of Maryland School of Medicine, where he oversaw the expansion of clinical practice sites, including the first in the region, the Maryland Proton Treatment Center. He also doubled the faculty in the division and the division's research funding, along with the expansion of training programs offered by the department. He rose through the academic ranks to become a full professor in 2014. Before coming to the University of Maryland in 2002, he was a faculty member at the University of Texas MD Anderson Cancer Center. Dr. D'Souza has published 100+ articles in peer-reviewed journals and has served as principal investigator and co-investigator on several federal and industry-sponsored research grants. He holds over a dozen patents with additional inventions under evaluation. He has led the development of commercially licensed software and technology and has also played an active role in National Cooperative Group randomized trials. He received his BS in Applied Physics summa cum laude from Xavier University in Cincinnati, Ohio, his MS and PhD in Medical Physics from the University of Wisconsin in Madison, Wisconsin, and his MBA from Duke University in Durham, North Carolina, where he was a Fuqua Scholar and a Health Sector Management Scholar. Please join me in welcoming Dr. D'Souza.
Good afternoon, everyone. Thank you for. Can you hear me?
Yes, we can. Sorry about that.
Great, thank you. Thank you for that kind introduction. Good afternoon, everyone. I want to take a moment and thank the Department of Medicine and the Institute for Clinical and Translational Research for the invitation to come and speak with you today. And in particular, would like to thank my friend and colleague and partner in crime, Dr. Steve Davis, for this invitation as well. Let me see if I can share my screen here. Can you see my screen?
Yes, that looks good.
I always find that it's useful to ask that question to avoid me speaking for the next hour and then only to realize that I hadn't shared my screen or that people couldn't hear me. So thank you for the confirmation. What I wanted to do today was just share with you an overview of data and informatics as the foundational element for clinical and population research, particularly within the University of Maryland, Baltimore, as well as the medical systems ecosystem. And in the context of that, sort of introduce you to or perhaps reinforce some of the considerations and opportunities that lay before us. I have no conflicts to disclose as it pertains to this particular presentation. So given the fact that we are in the midst of a pandemic, I'd be remiss not to start this presentation without some reference to COVID-19 and some of the ongoing work within our community at large here at the University of Maryland. And so one of the areas where informatics is starting to play a role is in the support of a rather large COVID-19 community research partnership that is led locally by Dr. Wilbur Chen. The goal of this study is to understand how possible exposures may potentially lead to infections, as well as identify where rates of COVID-19 infections are growing. So this is a multi-institution study where informatics is certainly playing a very key role as in a support mechanism whereby data for enrolled participants in this study is extracted from our EMR in support of the investigation. And so in particular here, the types of data that are extracted and provisioned on a monthly basis include demographics information, observations, which is simply labs data, behavioral information, diagnoses and other problem conditions, immunizations, encounters, medications, and procedures. And all of this data gets bundled from the medical system into a coordinating center that for this particular study is housed at George Washington University. Now, all of this has taken a lot of work and a lot of effort over many months to reconcile not only the technological aspects associated with the study, but also the process-related aspects associated with informatics. In particular, the establishment of a tripartite data use agreement, which is the underpinning for the sharing of a lot of this sensitive data between UMB, UMMS, and George Washington, which again serves as the coordinating center. Another example that I wanted to present before diving into the more general elements of informatics is collaborative work that we have done with two Department of Medicine faculty, including Dr. Mangla Gulati and Dr. Nidhi Goel, around the development of machine learning and artificial intelligence to identify in advance the likelihood of inpatient deterioration over the next 12 hours. So while there are many so-called algorithms that typically masquerade as predictive algorithms, but in fact are more detective in nature. In other words, they tell you what is going to happen right now, as opposed to what is going to happen in the future. Those are the distinguishing elements between detective and predictive algorithms. And so what we've done here is try to change the paradigm for how we intervene or the triggers by which to intervene in patients who are likely to deteriorate 12 hours in advance of such an event. And we've been using machine learning or AI in order to make this happen. Now I'll show you what used to be in place and how what we have done compares in terms of accuracy to what was in place. So what we do to evaluate such machine learning algorithms as well as AI approaches is use a metric called area under the curve, or AUC. And I'll show you in a minute what that means. But in order to evaluate the efficacy of these or the accuracy of these algorithms, this measure ranges from 0.5 to 1, where 0.5 is simply a coin flip, meaning you will do no better than random chance, and 1 being perfection. And so if we look here on this slide, what the performance of the model that we have developed looks like in comparison with the National Early Warning Score, which is a variant of the earliest early warning score system. The new system or National Early Warning Score was developed by the Royal College of Physicians in the UK. The curve here shows you the performance. And so this is an area under the curve for those of you who may not be familiar with this. What we like to see is a curve that has a very broad shoulder, like the red curve here. So this shows you the comparison of the news algorithm 1 hour in advance of the event, 12 hours in advance of the event, and the model that we have developed, or the algorithm we have developed, which again predicts 12 hours in advance of a catastrophic event. As you can see, On the right-hand side, the AUC values are characterized. Now, just to give you some context, as I mentioned, an AUC value of 0.5 indicates random chance. Anything lower than about 0.7 to 0.75 is really not worth talking about in terms of accuracy. And anything greater than 0.8 is when folks like me get extremely excited about the accuracy of such machine learning or AI type algorithms. Clearly, you can see that the model that we have developed outperforms not only the news algorithm, but also several other commercially available algorithms as well. While this may in and of itself be an interesting academic exercise, we've actually deployed this in a pilot form in the Department of Medicine with Drs. Gulati and Goel. And so this sort of gives you an overview of how informatics is at play, and we are harnessing data in order to truly impact care at the point of delivery. So we have data coming in from a number of different sources, and you don't, these are all the details of how the data is conditioned, acquired, provisioned, and then processed. But it essentially goes into this AI engine, if you will, and then the AI engine triggers a whole workflow that you see over here on the right within Epic. And again, this workflow was developed with active participation and buy-in of all of the stakeholders, including providers and nurses, so on and so forth. And this is all built into Epic. So this is not a entity that sits unconnected to Epic. We have made a concerted effort to take the engine, the AI engine, and then interface it with Epic in order to provide the appropriate triggers. So all this to the lead up to say that data is fast emerging as an undeniable asset in healthcare. In fact, it is ubiquitous. For those of you who may have spent time on your phones, either just prior to noon this morning, no surprise that you have been generating both your own or extending your own personal footprint digitally, as well as allowing a lot of tech companies to amass even more incremental data about you. So data is, in fact, the new oil. So this was an article that came up in The Economist in 2017, where they suggested, the authors suggested that oil is no longer the most valuable resource in the world, rather data is the most valuable resource in the world. And just to give you a sense of the proliferation of healthcare data, healthcare data is growing at an astronomical rate, as you can see both from the curves on the left-hand side and the right-hand side. And we are not, I remember when I was in graduate training, we used to think at the time, gigabytes of data were large amounts of data. Well, we've vastly surpassed gigabytes of data, and now we're not only talking about petabytes, but exabytes of data. And so what is an exabyte? An exabyte of data is actually 1 times 10 to the 18, so that's 18 zeros, bytes. That is the volume of data that we are talking about. So it is coming in fast and furious, and we need ways, scientific ways by which not only to manage this data, but also process this data, interpret this data, and harness it in healthcare. One other point here is that a large segment of the data continues to be unstructured. So if you think about data that exists in clinical notes, image data are what we would classify as truly unstructured data. And that is the type of data that requires an additional level of expertise and processing power in order to leverage and interpret that and make it usable in our various care paradigms. So the notion of big data has been around now for quite some time and has been used very effectively by lots of entities to generate buzz and marketing blitzes. But in essence, there are four, what we call the four V's of big data. And really their volume, which is just the amount of data that we are producing. And no doubt in healthcare, we are producing a vast swath of data. But most importantly, I would argue that what makes healthcare data rather distinct is the variety of data. So unlike a lot of other industries where there is perhaps even larger volumes of data, what makes healthcare data particularly challenging is the variety of it. It's not just EMR data, potentially DNA, there are gene sequencing data, imaging data, healthcare payer claims data, social determinants of health, which I'll talk about in a minute, but all kinds of data that are now relevant and implicated in managing the health of populations as well as individuals. There's also the velocity of the data. As I mentioned, data is being generated incrementally at an astronomical rate. And if you saw from that curve on the previous slide, that curve isn't a linear curve. It's a bit of an exponential curve, which means that the growth in some ways is going to be unbounded as we evolve into the future. And then the other thing that is important in healthcare is the veracity of the data. This is an often ignored and an element that is not talked about in great detail in healthcare. It refers to the quality or validity of the data. I subscribe wholeheartedly to what I call the GIGO principle, which is garbage in equals garbage out. And so paying particular attention to the quality of the data or the completeness of the data is a rather important thing that we in healthcare need to pay attention to. And I'll talk a little bit more about how this bleeds into the notion of data governance and all of our responsibilities in ensuring that we are good stewards of data. Now, as data is proliferating at a rapid rate, so is our ability to process or compute data, as well as develop algorithms. And so Moore's law, which essentially looks at how processing speeds have evolved in technology. In fact, the number of transistors that now end up on a microchip responsible for computing essentially double every 2 years. So if you just think about that for a second, it is phenomenal and almost shocking to grasp the rate of growth at which compute power is increasing. So what's interesting about Moore's law is when you plot the rate of growth of computational power on a log curve. So the y-axis here is a log curve. It's not a linear curve. If the growth was in fact exponential, we would expect to see a line. But in fact, what we see here as over the last 120 years is that this rate of growth in compute power is exponential on a log curve, which means it's an exponential of an exponential. So it is phenomenal the rate at which progress is happening in terms of compute power during our lifetime here. And on the right, what you see is a term that was invented by a rather eccentric futurist by the name of Ray Kurzweil, who posits that at this current rate of computational growth, we would expect the number of computations to almost emulate human brain capacity sometime in the very near future. So if you just extend, the blue dots are actual data points. And so if you simply extrapolate this, you would imagine that sometime in the 2030s and 2040s and beyond, the ability to conduct the number of computations per second or per hour is going to be truly unprecedented and perhaps may even vastly exceed the emulation of what he refers to as human brain capacity. So all of this is juxtaposed, interestingly, with the transformation that is taking place in healthcare. Many of you may know that the US healthcare system is struggling with the aspects of access and uneven quality. And there has been a slow transition in terms of our models, which are primarily based in fee-for-service, to a more value-based or quality-based outcome measure. And the incentives are slowly aligning with that in mind. This is a slow transition and obviously a very difficult one, but I introduced this simply to suggest that data and informatics is going to play a key role in helping us make this transition. And so if we focus now on what are the big domains of healthcare data that we're dealing with. So most of us are very familiar with clinical data. This is what we interact with every day. I'm sure many of you have already interacted with the Epic system sometime in the last few hours. There's a tremendous amount of information now stored just even within our University of Maryland health system, the entire ecosystem, where we have roughly data from roughly 4 million individuals that have at some point had interactions with the University of Maryland medical system. That is a significant amount of data. In addition to that, there is data that is provisioned from payers. And the reason why payer data is important is because while clinical data is maybe restricted to a particular health system or rather defined ecosystem, payer data gives you a more full 360 of the patient interaction. So in other words, if a patient is seen at the University of Maryland Medical Center, but then has an encounter at a MedStar facility or a Hopkins facility, while that may not be reflected in detail within our domain, that data could become available through payers who are agnostic to where those events or encounters take place. There's also pharmaceutical data, which primarily resides with pharmaceutical companies and through various sponsored research agreements or contractual agreements may also exist in academia. And then there's a growing, burgeoning volume of data around patient behavior and sentiment data. If you think about it, patients spend the vast majority of their time outside the four walls of the hospital or outside the four walls of a doctor's office. And that is where the bulk of the data is generated. And we need to start thinking about ways of how to harness that if we're truly going to make an impact in healthcare at large. I won't belabor all the types of EHR data, but just to highlight, this slide essentially lists out the various domains of data, all the way from demographics to behavioral data, vital signs to lab data, medications, procedures, free text, and imaging. And so while most of us are familiar with EHR data, there is a whole world of non-EHR data that is coming into prominence as it pertains to healthcare, including the US Census data, so socioeconomic factors and how those might play into someone's health, access to care, as well as patterns of care, food data, the diet, particularly when it comes to chronic conditions, people's diet and their ability to access food, that if they live in food deserts, how that may impact things. Even weather data, believe it or not, weather data is significant. There's literature that suggests that weather influences people's ability to show up for PCP appointments, primary care physician appointments. So all of these things are becoming more and more relevant, and our awareness of it and our ability to harness this data is particularly impactful helpful from the standpoint of decisions and the interventions we in the healthcare field might make. Now, all of this, the lens that I was using was sort of the macro approach or the macro aspect of looking at populations of data. But when you look at individuals, and the data footprint that an individual generates is also substantial. The data that we as individuals generate, both in the healthcare domain and the data that might be relevant in the healthcare domain or to our health, both from the behavioral aspect, so whether that's sensors, which are becoming more prominent in healthcare, our ability to remotely monitor patients, how we spend our time perhaps outside of the healthcare ecosystem. There's social data. There's also financial data, which could be potentially leveraged. Now, there are obviously lots of concerns around privacy issues, and I'll talk a little bit about that. But this is all leading to the fact that healthcare data is not just a singular aspect of looking at just what's in the EMR, but rather the other ancillary elements that are also going to be highly critical in addressing healthcare at large and individual interventions for our patients. So I see that there's a question which I will come to, I believe, at the end of this talk. So I don't want to, whoever asked the question, I want to make sure that I'm sensitive to the fact that I do see the question and happy to address it. I want to move on to what is then informatics. I've talked a little bit about data. What role does informatics play? So informatics is what I call sort of the sausage making factory, which is simply taking the crude in the form of data and harnessing data to leverage a number of benefits, both the accelerated rate of scientific discovery, improved clinical decision making, and that's both at the population level as well as at the individual level, and the ability to promote behaviors to affect health at a population level, especially relevant to the way we in Maryland and our healthcare system operates under a global budget and the incentives and disincentives by which we operate within the state of Maryland. And so the data or the inputs, if you will, to what informatics can do range from electronic medical data, payer claims data, medical images, DNA sequences, all of the above. This is a nice summary that that Washington University, the Institute for Informatics at WashU actually put out. And it captures very nicely the elements of, or the various elements of healthcare informatics that are particularly relevant to a lot of the things that I think we are doing right now within the University of Maryland, Baltimore, and University of Maryland medical system ecosystem at large. So there is, I know of a lot of work happening in the translational bioinformatics space where we are transforming voluminous amounts of data into proactive, predictive, and preventive health for various segments of the populations that we treat and intervene in. I'll come back to precision medicine because I know that that is near and dear to perhaps some folks on this call. But even things like mobile health and the use of real-time continuous biological, behavioral, and environmental data that's collected using mobile technologies and integrating those technologies within our our traditional EMR systems, if you will, in order to affect care. There's the more traditional element here on the right of clinical research informatics, which is something that a number of investigators on the UMB campus may be quite familiar with, where data serves as the engine to drive whether it's feasibility assessments of retrospective investigations or prospective investigations culminating in randomized clinical trials. There's also this aspect of learning healthcare delivery systems that was coined by the Institute of Medicine now about a decade ago, where the argument was made that healthcare delivery systems inherently ought to be learning from daily actions. So everything we do on a daily basis it creates nuggets of data that we can build upon to eventually harness and create a inherent learning system in order to improve the care of the individuals we manage. Obviously, the topic of precision medicine is a big one, and in many respects identified as the Holy Grail, where if we can harness a lot of this data to then intervene on what I call an N of one, which means an individual, as opposed to just a population. It opens up avenues to identify new ways to treat and prevent particular diseases, test whether behavioral interventions can encourage healthy behaviors, again, targeted for an individual, and then developing the right drug for the right person at the right time. This next slide illustrates what may be a common pain point that many of you may have encountered already, where as we talk about all of this, data and informatics, it lends itself to the question of, do we have a robust informatics infrastructure? I would argue that every healthcare ecosystem now should have a robust informatics infrastructure, because if we are to leverage everything that I have just talked about, it needs to be appropriately managed and provisioned, as opposed to perhaps what we could have gotten away with 10, 15 years ago, which is managing things in silos, in loose, fragmented manners. Those days and that ability, given the rapid growth that I've articulated in data and information, is simply not tenable. And so here are just two examples of what might be use cases that individuals, some of this may seem familiar to you, where a particular investigator may need access to very robust data across several domains in order to either assess the feasibility of a potential prospective study or trial, or to be able to conduct a moderate to large retrospective investigation. There's also this use case of multi-institution research. So if we look across the country, there are significant investments being made at major academic institutions into the provisioning and development of robust informatics infrastructure, so that there can be more seamless integration and knowledge sharing in multi-institution trials and multi-institution research projects. So what are we doing here at UMS and UMB? There is a concerted effort that's underway to try to figure out how to assemble this robust informatics infrastructure, given that we have the complexity in data and information and knowledge that's being generated and currently exists across our ecosystem. And to facilitate the trend in healthcare towards interdisciplinary, integrative, and data-intensive research and discovery. And so in order to do this, we're going to have to move from our current state, which is articulated here, where data is accessed in a rather ad hoc and fragmented manner. Investigators have access to limited data sources because these data sources are not necessarily curated and optimized for access that's conducive for research. And oftentimes, some of this data is maintained by individual investigators, which makes proliferation, support, and maintenance of this data over time rather untenable. And it also exposes risk to organizations because of the risk of breaches or security-related instances for such data. A piece of good news in this direction, Trinetics is something that we will start introducing to the community at large within UMB and UMMS, is a step in that direction to try to consolidate at least some aspects of our EMR data into a quote unquote centralized self-service accessible repository. So Trinetics is essentially a health research network. Think of it as a loose repository by which investigators would be able to, through a self-service mechanism, be able to assess feasibility or aggregated counts of particular inclusion-exclusion criteria, depending on the studies or populations of interest. What we are trying to do, again, with Dr. Davis's help and with his leadership, is trying to evolve into a much more sophisticated ecosystem, whereby we would like to leverage the infrastructure that has been invested in and developed over the past few years at the University of Maryland medical system. And off of that backbone, extend the informatics core for UMB by leveraging the existing assets in order to service the entire UMB community. And so conceptually, this is what a future state would look like, where we would have data that would come in from various sources, and it would go into this conceptual research data management platform, which we ultimately intend to be a physical entity as well. And within that entity, there would be various grades of data and access and security that would be established so that investigators would have access to, with proper guardrails and IRB approval, either full PHI or limited data sets or de-identified data. And I'll talk a little bit more about what each of these things are, because again, part of understanding our role in the data and informatics ecosystem is also understanding our responsibilities of the stewardship of our patients' data. And so what we're envisioning is actually not quite different from what perhaps the most progressive health system in this space has done, Vanderbilt Health System, that has a similar structure that has been established under their research derivative. All right, so those are some of the technological elements. I want to pivot now to this notion of what I call data governance. And so this is not just about the technology. What do I mean by data governance? So here's a brief history lesson for those of you who may be history buffs. The Battle of Austerlitz in 1805 was between Napoleon's armies and the Third Coalition, which included Britain, Russia, and Austria at the time. And so the plan was for the Russian and Austrian armies to meet on October 20th. The problem was that the Allied planners failed to realize that the Russians were using the Roman calendar and the Austrians were using the Gregorian or Christian calendar. So they agreed on October 20th, except they didn't reconcile the differences in the calendars, which were 12 days apart. And so October 20th meant different things to the Russians and the Austrians. So the Austrians were defeated because the Russians didn't arrive in time. And by the time the Austrians were defeated, the Russians arrived late, and they too were defeated by Napoleon's armies. So the speculation is, perhaps common terminology could have turned the tide in this battle. It's more of a tongue-in-cheek sort of comment there. So what is data governance? At the very minimum, there are various definitions, so you can look up, there's lots of articles that have been written on the notion of data governance. There have been books that have been exclusively dedicated to this principle and notion. But at its core, data governance is simply an attitude. It recognizes that data is an important asset for any organization that dabbles in it and uses it for its core businesses, which I would argue in healthcare, data is a key element of how we go about managing our patients using evidence. And so we should be applying the same rigor to managing this asset as we do for any other asset within our institution. And this is why, if you recall, I started off by saying, data is and is ubiquitous, but it is also undeniably now perhaps the most important asset for every organization. So very tangibly, what does data governance mean? So I've included an example here of what data governance might, from a practical sense, might mean. So here's an example of a health system that was evaluating whether for core measures, so again, established by CMS, they should be using data manually abstracted from patient charts, or whether they should be resorting to data electronically captured from the EMR. Obviously, it would be a lot easier if they could electronically capture it. But when they set about to do this and they did a head-to-head comparison, they found a huge discrepancy in the compliance between chart abstracted measures and the same measures that were abstracted electronically. So why was this? So as they set about their investigation, they realized, and they conducted interviews with the nursing staff, they found that there were 3 different workflows and associated screens within their EMR system where the removal of urinary catheters, which in this particular case, this is one of the core measures that they were looking at, was documented in the EMR system. So in order to address this, they had to undertake a campaign to teach and reinforce the concept of a single workflow. I am sure that many of you can relate to this, knowing that in our EMR system, Epic, there are likely more than one, there's more than one place to document certain pieces of information that are similar in nature. And as a result, depending on whose definition or who is looking for the data or the information, you may get different answers. And so being able to govern some of the inputs in order to manage the whole garbage in, garbage out principle becomes extremely important. In the interest of time, I'm going to skip forward here. I want to just give everyone a sense of there is a science to how we manage data. So while we loosely think about discrete elements of data that are generated from an informatics perspective, there are some standards. There aren't great standards widely distributed in the healthcare community at large, but there are some ontology-like vocabularies that we all subscribe to. And so some of these may look familiar to you, like ICD-10, the International Classification of Diseases, LOINC codes, which is essentially a database and universal standard for managing medical laboratory observations. the national drug file, which is typically used by VA hospitals and clinics, RX norm, which is again standardized nomenclature for clinical drugs produced by the National Library of Medicine, SNOMED CT, as well as, again, happy to, if anybody's interested, happy to share more information in this regard around some of these well-established vocabularies. So why does all of this matter? Part of data governance also bleeds into, again, raising awareness and education around our roles and responsibilities in both using data, managing data, and stewarding some of this data. And so in that light, there are actual federal regulations around patient privacy and the data associated therein. There are three broad HIPAA classifications for data. There is what we call full PHI, which is essentially all kinds of identifiers. There is limited data set and a de-identified data set. Limited data set essentially strips out 16 of the 18 elements that are classified as full PHI. And I won't go over all of these, they're on the list. So I believe the presentation will be made available for those of you who may want to peruse through this in slightly more detail. But the difference between a limited data set and a de-identified data is essentially these two elements here. So 16 of those elements are common to the LDS as well as de-identified data. But in de-identified data, we are stripping, in fact, geographic subdivisions that are smaller than a state, including street address, zip codes, city, counties, etc., and all elements of dates. So things like birth date, admission date, discharge date, so on and so forth. And in fact, in some of our work, when we talk about de-identified data, we are able to obfuscate dates so as to not be able to re-engineer and re-identify people through those mechanisms. There are actual methods that have been codified by the HHS in terms of what determines de-identification. And so there are two methods. One is an expert determination and one is safe harbor. Safe harbor is essentially removal of particular identifiers. There's 18 of them. Expert determination is really the reliance on an individual who is deemed an expert in this area, whereby they can essentially certify that using statistical scientific principles, any reasonable individual is not able to re-identify individuals. Now, having said that, I'll tell you there was an interesting article, and this came out almost 20 years ago from Carnegie Mellon, where investigators, researchers there showed that at the time, 87%, almost 90% of the US population is identifiable using only three characteristics: their 5-digit zip code, gender, and date of birth. So when you think about, is Big Brother watching? The answer is yes. It is not that hard, in fact, with the technologies available these days to identify individuals. And so scrutiny around these things has increased, and our ability to become more sophisticated in this area is paramount. I'll quickly transition to the fact that healthcare data breaches are on the rise, and this is why, so if you're wondering, why is he making a big deal out of all of these things? Because we have to. We live in an era where the bad comes with the good, and so if you look at the rise in the number of healthcare data breaches since 2009, so just in the last 10 years, this is substantial. And when we look here on the right-hand side to the number of individuals that have been affected by healthcare data breaches, this is not a trivial number of individuals on an annual basis who are impacted by such breaches. In addition to data breaches, there's also the inappropriate access or unauthorized access of data. sometimes by healthcare workers. Those things are also on the rise. In fact, the number of records that are compromised in such instances or events is also not trivial, as you can see here on the scale on the y-axis here on this curve. There are penalties associated with such violations. In fact, there is enormous risk to the institution for each of these violations, and some of them have to be disclosed to appropriate law enforcement authorities for investigation. So I want to end on a positive note. While all of this is important, the opportunities are substantial for us in the informatics realm using data. There is a substantial emergence of machine learning and AI in healthcare, whether it's imaging, so being able to identify disease states using CT or MR or ultrasound data, to using AI in virtual reality in surgeries, and being able to do that is ever growing. There was a nice article, a review article that was written a few years ago in the New England Journal of Medicine, which categorizes three broad areas where they believe machine learning is going to have an impact. One in prognosis, so being able to predict events in the hospital or outside the hospital, and may have particular relevance in infections, hospital readmissions, healthcare utilization, mortality, etc. Interpretive medical specialties like imaging and pathology, where typically we're looking for malignant or benign states and interpretation of such unstructured image data, and then diagnostics to perhaps mitigate against the errors that continue to exist at a high rate using machines to actually address some of this. You'll realize I'm a bit of a history buff here, and so I try to relate some of the origins of why certain things came into place or how they came into place. A fun fact here, machine learning was actually invented or is ascribed to this individual, Arthur Samuel, who in 1955, it's the first known example of an individual programming a machine to learn without explicitly giving it instructions, like in a software program. So the way machine learning works is there is an underlying algorithm, but it is conditioned to explicitly learn from prior events and then make decisions on future events. And so he actually developed this machine for the purpose of playing and winning checkers. In fact, the machine got so good, it was actually quite capable by the mid-70s of beating capable human players. I'm going to skip over a couple of slides just in the interest of time and just give you a sense of machine learning and its utility in healthcare. There are numerous problems. So we live in a problem-rich environment where machine learning could have an impact, from the ability to predict flu seasons, to identifying the risk of developing diabetes, to identifying in advance patients who are likely to develop severe sepsis, to a patient's risk of hospital readmission. There are a lot of elements that have to be factored into machine learning. I caution against picking something off the shelf and saying, we'll plug things in and use it, and we're doing machine learning. In fact, there are lots of nuances that have to be considered when we use machine learning and AI, because what we want to do is avoid situations like this. Someone comes in, rapid pulse, sweating, shallow breathing, and you plug it into the machine learning algorithm, supposedly, and it tells you you have gallstones. Not really. The last point here is bias in AI and machine learning based systems. There much is being written now in this area. There are human biases that machines tend to learn, and then there's also data scarcity where particularly disenfranchised groups are not considered in algorithms and in training models where AI and machine learning based systems are considered. So we need to remove our blind spots and be much more considerate of such inherent biases when we embark upon this type of work. But the future is rather bright and the opportunities rather vast. So with that, I will stop and happy to take questions. So I know that there was a question that came in very early, which said, can you expand on how is census a social determinant of health? So the US Census Bureau puts out data that is available at the block level, so not the zip code. In fact, happy to have a conversation offline for those of you who may be interested. The zip code, while may be instructive in some ways, is not very useful in other ways. The block level is something that is much more indicative of things like socioeconomic conditions, so income levels, and things like that are direct correlates or related to aspects in determining somebody's health outcome or perhaps their ability to access care or their ability to even follow care regimens. So those are all aspects of how the census data could be instructive and a rather useful proxy in the whole social determinants of health paradigm.
Thank you, Dr. D'Souza. Also, everyone else has been unmuted if they wish to ask any questions out loud. Additionally, you can type in the chat box or continue to type in the Q&A.
Curious, first of all, thank you for the presentation. From the PDR scores, have we found, has there been any indication that we've made impact as far as like, you know, decreasing events, like having impact with the evaluations that the residents are doing, or is that just still kind of in process?
Yeah, thank you for that question. So great question. We are in the process of doing just that. So we are looking at determining how to prospectively evaluate the efficacy of the PDR score. So this is the identifying the risk of inpatient deterioration in medicine over time. One of the challenges with doing that is the ability to document events. So, you know, one of the triggers, which you may be familiar with, is the actual huddle, that the bedside huddle, and various other process measures that are triggered by the algorithm. Being able to record that is something that is a bit of a gap and an opportunity for us, which we are trying to address. Other things that we are trying to do is link up even things like the pushing of code blue buttons, as if you will, and being able to identify when that happens in the process. Those things are going to be instrumental in us being able to truly evaluate the efficacy of the intervention.
Thank you. There's a second question by Barbara Hutchinson. Do you think that in the next few years, as AI increases in healthcare, that this could negatively affect reimbursement to providers because part of our work is now done by a computer?
Yeah, so, you know, so I hear this thought or sentiment that is expressed of whether, you know, robots or machines are going to replace humans. And my answer to that is, I don't think so. Are there going to be low acuity functions that potentially could be replaced by machines? The answer is yes, absolutely. But I think that it is fundamentally going to change, in all likelihood, the way humans or providers interact with our current systems. So AI is intended to hopefully remove some of the drudgery and some of the tediousness associated with tasks. But I don't see robots or machines exclusively replacing humans. Now, there may be folks who may disagree with me, but I think we're, I don't see that sort of on the horizon.
Thank you. The second question that we have is from Anthony. Could you touch on data to quality of care? Is there efforts to allow a provider to use Epic to manage the quality of care to their outpatient panels?
Yes, I'm not sure I fully appreciate the extent of the question, but if the question is, is the data available in order to perhaps serve as the guide for your particular panel in the outpatient setting? The answer is it can be curated in a way in order to make it available, a provision in that way to provide that feedback loop, if you will. But EMR systems weren't designed to necessarily provide the intelligence. They're evolving, but directly out of the box, they're not necessarily designed to provide that kind of intelligence function to providers. And so we have to add in the layers that are necessary in order to provide that intelligence, whether it's in the form of dashboards, scorecards, or other more real-time triggers to facilitate that kind of information. I don't know if I answered the question or understood the question, but happy to, if you'd like to clarify.
Yeah, that's hi, it's Anthony. That's the question. How do we? I think a lot of us hope that electronic records would give us the opportunity to really use data to what I would call data to quality of care, so that you can look at dashboards and understand if you wanted to know how many of your patients received a COVID vaccine, for instance, and you have 400 patients that you're caring for, and in a manner that's very easy to use, that providers could add additional outcomes that they want to measure, so they understand what the quality of care is. And I think that's been a difficult challenge. So that's what I think you touched on what I was asking. Thank you.
Great.
Thank you, everyone, and thank you, Dr. D'Souza. I think that's all the time that we have for questions. Thank you again for wonderful grand rounds, and have a great Wednesday, everyone.
Thank you.